Medurstand, Understanding Medicine.
I'm Professor Aziz from Medurstand, and we're going to start a series of lectures on hypertension. There are going to be at least 3 of them. Today, we will talk about just the diagnosis and the initial evaluation of hypertension. Hypertension is an extremely important condition, very prevalent, and the biggest single killer of mankind. So we need to understand this condition very well, and we have to develop a strategy how to properly diagnose and treat these patients so that they can get away with the complications. Uh, this talk has got 5 agenda items. First of all, how to make a diagnosis. And then we will talk about the basic labs which we recommend in almost all patients at the time of initial diagnosis. And then we have to examine the patient and do some necessary lab to see if there is existing hypertension mediated organ damage, because hypertension could remain undiagnosed for years, and it is actually possible that at the time of initial diagnosis there are already some complications. Then we have to determine the presence of comorbidities. There are several comorbidities which can alter the natural history of hypertension, which can alter the choice of therapy, and also will decide how frequently we need to call these patients for follow-up. And then finally, every patient with hypertension is not the same. We have to determine their overall risk. Hypertension itself is almost asymptomatic, but it is notorious to cause premature death due to several complications. And we have to determine the risk in every individual so that we can choose the proper therapies for that person. So let's take up all these agenda items one by one. First of all, diagnosis. Diagnosis, of course, is important. In hypertension, diagnosis is easy. All you have to do is to measure blood pressure, but very carefully with a standardized apparatus, usually more than once, and you could measure at home and you could measure in the clinic or office. So I think after you have taken multiple readings, only then you are sure that you have this case. First of all, history is important. Many patients, they attribute their symptom to hypertension, but we know that hypertension is mostly asymptomatic. But we must know, we must take a detailed history, because history can give a very important clues to the possible cause of hypertension and also indicate some of the contraindication for some medication. So a detailed history is very, very important. And then accurate measurement. You need to have a standardized blood pressure apparatus. These days, these digital apparatuses are recommended, but in our society, we still believe that Mercury 1 is better. But I think Mercury 1 may not be better, because you need to have to develop skill to accurately measure blood pressure with Mercury apparatus. So I think patients can be instructed to use their digital meters, but they should be explained how to properly use them. All meters, they have their instructions with them, so I think they must be followed. One basic principle is that patient must be seated for at least 5 minutes in upright position in a comfortable chair with legs hanging on the floor, with the feet resting on the floor, and patient should not have consumed any stimulant, and patient must be physically and mentally relaxed, and then blood pressure should be measured. And typically we measure 2 or 3 times, and then we take a mean value. If all are above normal, then of course diagnosis is clear. But if some are within the normal, others are in the abnormal range, then maybe you need to call the patient again for repeat readings. Multiple readings, as said, as if one reading is very, very high, then of course you may not take multiple readings, but borderline reading must always be repeated. and rule out acute cause. Now, blood pressure varies with our physical state, with our mental state. Now, we call hypertension as a disease only when it is persistent. So there could be a situation, physical or mental, which may have caused just temporary rise in blood pressure. That would probably need just a reassurance, but you have to rule out any acute condition that could be responsible for this temporary rise. Then, if possible, I think home blood pressure monitoring and ambulatory blood pressure monitoring should also be done. May not be possible in all cases in our country. Home blood pressure monitoring has the plus side. The plus side is that when patient is relaxed at his own comfortable place, and if the readings are high, that truly indicate that the blood pressure is there, hypertension is there. But then it depends on how accurately these readings were taken. Then ambulatory blood pressure monitoring is again a great tool, but it's not widely available in our country yet. So we use ambulatory blood pressure monitoring sparingly, but we do encourage our patient to take their BP reading at home. So if reading at home are high, that surely indicate the patient has hypertension. So this was about the diagnosis, and now let's take the next agenda item. So before that, I think on the basis of this history and detailed examination of blood pressure, measurement blood pressure, what we will do is we will determine the category of the patient, and is it upper normal blood pressure or it is hypertension, which stage 1 or stage 2, or is it isolated systolic hypertension, or is it white coat hypertension, or is it masked hypertension. The white coat hypertension is the type of hypertension which is present only in the doctor's presence, in the office or in the clinic. At home, readings are normal. Masked hypertension is just the reverse. Now, this is a patient where reading at home are high, but when patient comes to the clinic, the readings are normal. This is a strange phenomenon, but this is also a morbid condition. This needs to be treated. Then we have to see if patient has got hypertensive urgency or hypertensive emergency. These conditions will also be discussed subsequently. So I think in the initial evaluation, not only we have to establish a diagnosis, we have to actually assign him the category so that we can follow him up properly. So we have done with this diagnosis part, and let's take the next agenda item. The next agenda item is basic labs. Now, I think we have to be very choosy. When we decide basic labs, we are a resource constrained society. We can't just have every test. And in fact, I believe in every society, you have to reserve resources. So I think only those tests should be done which are going to be useful, and others should be done if the initial evaluation indicate that there could be some problem and we have to do tests for that. So, but these basic labs should be done in all cases diagnosed with hypertension. Now, one thing I would like to say is that it's not that you have to complete these labs before you can even start medication. This we have to make a plan, and this plan can be completed in maybe 2-3 months. We can establish a diagnosis, we can start medication, and meanwhile we can also do the tests as the facility becomes available. Urine analysis, I think if I have to pick up one single test, that would be urine analysis. Simple urine examination is very useful in the context of hypertension. Of course, in majority patient with hypertension, we expect urine examination to be normal. But if it is not, if there is protein present, if there are casts present, if there is the active sediments, RBCs are present, white cells are present, that could indicate presence of nephropathy, and that nephropathy could actually be cause of hypertension or could be the effect of hypertension. So that will determine the overall prognosis. So urine examination is extremely important. Then creatinine should be measured. It's a simple blood test, and I think based on one's creatinine and also based on one's age and weight and gender and ethnicity, we should calculate GFR. Very, very important, because same creatinine in two persons of different weights could mean altogether different things. So we must always calculate GFR, and this word E means we actually estimate. We don't actually measure GFR. We estimate GFR based on one's creatinine. And different apps are available, so you could use one of those apps and determine one's GFR. So that would indicate that if kidney is all right or if kidney is already affected. Then serum electrolytes, very important again, especially potassium. Now there are some conditions uh, where there is hypertension and there could be hypokalemia. If somebody exhibits hypokalemia during the initial evaluation, I think first of all you should make sure that patient is not on diuretics already, or patient is not any diet restricted on any restricted diet. And then I think you should remeasure and confirm the hypokalemia is there. If hypokalemia is there, it could indicate towards some relatively uncommon causes of hypertension like primary hyperaldosteronism, Cone syndrome, or Cushing syndrome. So I think very important potassium. Sodium is also important. Then other electrolytes, if possible, bicarb chloride should also be done. But of all electrolytes, I believe potassium is the most important. Then abdominal ultrasound, very useful test, because in hypertension, two organs are very relevant. One is the kidney, the other are the adrenal glands. And with just one ultrasound, which is available in all health facilities, you could see the status of kidneys and adrenals. So if kidneys are affected, and it might show altered renal parenchyma, or it may show shrunken kidneys, fibrotic kidneys, or enlarged kidneys, and in the adrenals it may show a large size. So I think that will give very important clue toward the diagnosis of to the etiology of hypertension. So that is why ultrasound should also always be done in patient with hypertension. Then HbA1c. HbA1c is of course a marker of diabetes because many patients with hypertension, they tend to have coexisting diabetes also. Hypertension can actually predispose to diabetes. So HbA1c should be determined, and if that patient is diabetic also, then the choice of therapy may be different and our goals may be different. Goals where we would like to bring the blood pressure to may be different. Then again, lipid profile should be done because hypertension along with diabetes and dyslipidemia, they are all responsible for premature and accelerated atherosclerosis. So that's why we want to know the lipid profile. After all, we are treating a human person, a human being, not a condition. So that's why we need to understand that person completely. I think for lipid profile, it is best to have a fasting test. HbA1c can be done anytime. So on the basis of this, what we do is that we determine if patient needs further investigation. For example, if somebody has hypokalemia here, then of course we will have to have detailed imaging of the adrenals and maybe urinary ketosteroids derivatives and cortisol level and aldosterone level like that. So on the basis of these basic labs, which are economical, which are available, which are not invasive, so based on these investigations, we will actually pick up those patients who might need more investigation. Then I think those investigations may be justified only in those patients who need them. So this was agenda item number 2. The first we discussed diagnosis, And in the second part, we discussed the basic labs. I have already emphasized that all these labs are not necessarily to be done in one go. I think you could take maybe 2 weeks, 3 weeks before you can complete these investigations. Uh, Agenda item number 3 is this hypertension mediated organ damage. Hypertension is something which can silently damage one of the or multiple of organs. The organs which are particularly vulnerable is the heart, the kidneys, the brain, the eyes, the vessels. So I think we need to evaluate the patient from history, from physical examination and the labs to determine if the hypertension has already caused some hypertension mediated organ damage. That will put him in a high risk category. So how do we do that? First, of course, I think fundoscopy examination. Fundoscopy is very useful examination. Even if you just examine the fundus without dilating pupil, you would have reasonably good idea if fundus is okay or not. But best is to dilate the fundus and examine it properly for any hemorrhages or exudates. So if they are present, then arteriovenous leaking. So if that they are present, that would indicate a slightly higher risk of retinopathy. Then ECG and echo should be done. Uh, one can uh, one can argue whether they are needed or not. I guess ECG is very helpful. It is very reassuring, and echo is even better. The reason is that if any of these indicates left ventricular hypertrophy or diastolic dysfunction, so that would be actually a very strong point deciding that the patient is actually hypertensive or has been hypertensive for quite some time, and treatment is absolutely essential. Many times I've seen patients are double-minded. They would give you some lame excuse that they just took some extra salt today. That is why blood pressure reading is high. So if you can demonstrate that echocardiography is showing diastolic dysfunction or some left ventricular hypertrophy, you could then convince the patient that hypertension has been there for some time. That is why this complication has developed. So I think this is very useful test. And also left ventricular hypertrophy in itself is a risk factor for future atherosclerotic or cardiovascular disease. So I think we would certainly like to know if patient has developed any of this hypertrophy. On the contrary, if somebody has absolutely normal ECG and absolutely normal echo at the baseline, that would be very reassuring. In echo, we just ask for left ventricular size and the left ventricular function. We may not do detailed echo. And ultrasonography will also tell if kidneys have been affected, and albumin creatinine ratio. I think very important. Urinalysis I mentioned in my first slide, the basic lab. Urinalysis would demonstrate if there is macroalbuminuria. But macroalbuminuria means you need to have protein like more than 300 milligram per 24 hours. So if protein is between 30 and 300 milligram per 24 hours, that is called microalbuminuria. Now we know that microalbuminuria is an indicator of poor prognosis in the future. So one way is to collect 24-hour urine and measure protein, but that is very cumbersome. A better way is just to do albumin creatinine ratio in the morning sample. If this is abnormal, that would also indicate microalbuminuria. So I think on the basis of that, you can determine that kidney has already been affected. So patient has already developed hypertension mediated organ damage, and patient has already in the slightly high risk category. Carotid Doppler, one of the complications of hypertension is this atheroma formation in the carotid. So carotid Doppler, of course, before you do carotid Doppler, you need to auscultate the carotids, and if they're buoy, then or even if there is no buoy, carotid Doppler will be useful. But I understand this may not be necessary in all patients. But if the facility is available while you are doing echo, the same person can put the probe on the carotid and see if there is any problem in the carotids. So in this category, we will determine the choice of medication. Somebody with nephropathy might need different medication. Like for example, ACE inhibitors or ARBs may be preferred in that group, like that. And it will also determine the pace or the tempo of follow-up. Those patients who have developed HMOD, they need more frequent follow-up so that we can adjust their medication at a faster pace. So that is why it is important to have this detailed evaluation. So this is part 3, diagnosis, initial evaluation with the lab evaluation, and then determination of HMODs. And now the comorbidities. What are the comorbidities which may be present? They may be actually, there may be some common genetic factor or some common phenotypic, same phenotype may predispose to multiple conditions. So there are some medical conditions which tend to coexist with hypertension. Now we have to determine if they are present, because in that case we have to address them also. Otherwise the purpose of treatment will not be fulfilled, because we want patient with hypertension not to develop complications. Now if you just focus on hypertension and ignore the associated condition like dyslipidemia, and diabetes, then the purpose will not be fulfilled. So what are those comorbidities of diabetes? This we decided we will do HbA1c. Ideally, it should be less than 5.7. So we need to do that. And dyslipidemia, these days we use the word dyslipidemia. Previously we used to call hyperlipidemia. Now we know it is not just the quantitative abnormality, there could be some qualitative abnormalities also. I think a detailed fasting lipid profile should be done. I will have a separate lecture on dyslipidemia, but here I just would like to say that you need to have a fasting full lipid panel so that we can determine if patient has dyslipidemia. Then hyperuricemia, of some importance. Hyperuricemia, many times it coexists because there are some drugs like diuretics, thiazide type of diuretics, they may increase uric acid. So if somebody already has hyperuricemia, maybe if possible we should avoid those medication. Asthma, the relevance of asthma is that beta blockers, especially the non-selective beta blockers, they can aggravate asthma. So obviously we don't want our patient with hypertension, his asthma to be aggravated. So we need to know if patient is asthmatic. Then BPH, this is benign prostate hypertrophy, very common in elderly. So there are some drugs which are useful for both hypertension as well as benign prostate hypertrophy, hyperplasia. So I think it is also important to determine if patient has this comorbidity. And then this is very important, the status of heart. If patient has ischemic heart disease, then definitely that will affect the choice of our therapy and the pace and the tempo of follow-up, and perhaps the goal which we want to achieve. Then if patient has got heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, I think these categories definitely need to be defined. It is more likely that patient has coexisting coronary artery disease which has caused heart failure. It is unlikely that it is just a hypertension which has remained undiagnosed and patients that develop heart failure, but that is also possible. So we need to determine the left ventricular contractility status on echo. So based on this, we will determine the choice of medication and the goal BP and the tempo of follow-up. So I think this is very, very important. So this item is also now done. The last one in this lecture is determination of overall risk. Taking everything in consideration, we determine the approximate risk this patient has. The overall risk of developing atherosclerotic cardiovascular disease or premature death is based on several things. First of all, degree of hypertension, how high the blood pressure is and how high the blood pressure has been, and the duration of hypertension, how long the patient has been hypertensive. So that is one factor. Then additional risk factors. If patient has hypertension with dyslipidemia, with diabetes, with obesity, with smoking, of course, the risk will be increased. Then existing ischemic heart disease, of course, one of the major complications which determine the prognosis is ischemic heart disease. If somebody with hypertension already has ischemic heart disease, that will also put him in a high risk group. Then age, gender, and ethnicity, they also are determinant of overall risk. So we will consider all these factors to determine patient's overall risk. Now, it may not be possible to give a certain weightage manually. Think to help us, we have many calculators available, and they are mostly free and they can be downloaded to your small devices and you can use. So every patient needs a detailed determination of, I think, overall risk. The risk could be less than 10%, which is the average risk, 10 to 20%, which is moderate risk, and more than 20% will be high risk. So that is arbitrary division of risk categories. And so we have covered all this. My topic is diagnosis and initial evaluation of hypertension, and this consists of establishing the diagnosis, basic labs, determination of hypertension mediated organ damage, determination of presence of comorbidities and overall risk. So based on this, then we define the complete person, complete picture. Only then we know exactly, only then we understand this individual completely, and that gives us a complete picture. Now, for example, these are two scenarios. Now, stage 1 hypertension, like 160, like 155 by 95, okay, that stage 1 hypertension with no additional risk factors on one hand, and stage 3 hypertension with multiple risk factors or with diabetes or with existing coronary artery disease. These two individuals are wide apart, so they need altogether different types of plans. So I think, and then we have all the grades and shades in between. Very, very important. That is why we always say that the treatment plan has to be individualized. Now we have to decide where this particular patient sits between these two extremes. Accordingly, we make a plan for him. So, ladies and gentlemen, we are coming to the end of our presentation. To sum up, patient with hypertension need a detailed evaluation to determine the exact risk status, not just the measurement of blood pressure, but determination of comorbidities and his determination of his overall risk of developing atherosclerotic cardiovascular disease in next 10 years. And accordingly, we make the treatment plan. So, and this individual assessment refers to the diagnosis, the etiology, the hypertension mediated organ damage, the comorbidities, and then overall risk. Summary: initial detailed evaluation should lead to a personalized treatment plan. A personalized treatment plan in the sense that which medication, what dosage should be used, how frequently you need to call this patient, and what are your goals, what blood pressure you want to achieve. So I think all this needs to be done if you want to provide best care to your patient with hypertension. With that, I'd like to thank you for watching this video, and I look forward to see you in the next one, which would be on hypertension again. And I think we will discuss various therapies and various goals. So I really look forward to see you there. And this is Professor Azizur Rahman from Medurstand. Thank you.